Today we'll be talking about a very interesting chest X-ray. Now, what we can see in this X-ray is we can apparently see that this is the apex. This is the heart shadow. So we can trace the shadow, and this is apex. Now, what is apex? Apex or cardiac apex is the outermost. It is the lowermost part of precordium where a definite thirst can be felt, which is usually less than 2.5 centimeter in diameter and which is usually tapping in nature. It is usually always medial to the uh, midclavicular line, and it is around 4 to 5th intercostal space. So this is what is the definition of a cardiac apex. Now here, as I have told earlier also, just by seeing we can see that there is apparent cardiomegaly, means heart shadow looks very much enlarged. Now when to say that the patient has cardiomegaly, we simply take the diameter, this inner rib diameter, which is this much, and we take cardiac shadow diameter. So we have to take it from where you have maximum distance which can be calculated from the midline. So this is the midline. So you take from here to here and from here to here. So it is almost like this much, which is definitely more than 50% of this. So this is definitely more than 50% of this diameter. So this is definitely cardiomegaly. Now cardiomegaly, whenever we call it as cardiomegaly, we have to look for the apex. Where is the apex? Now apex is here. So the apex look much of outside the midclavicular line. It is much outside the midclavicular line, and it is pretty going downward. So it is going down and out. This is how we say it, down and out. Now you must know that whenever this left ventricular apex is going down and out, it is always because of the left volume overload. That you have to remember, because apex is a part of left ventricle, and why it is going down and out is all because of volume overload. So because if it is pressure overload, the apex will not go anywhere. If it is pressure overload, the apex will simply stay there only. So it will be medial to midclavicular line only. So if it is pressure overload, the apex will stay medial to midclavicular line only. Midclavicular line, and it will not go down or not go out. But whenever there is volume overload, because of increased volume of blood coming into the left ventricle, over a period of time, the LV keep on getting dilated, as well as hypertrophy, and that is the reason why the apex goes out and down. Now, what is the reason for this volume overload? If there is volume overload, there must be more and more blood coming to the left ventricle. Now, what could be the reason? The reason are very simple. Left ventricle is getting blood from left atrium. So normally left atrium pumps blood to left ventricle, and left ventricle pumps the blood to aorta. So basically, the LV to left ventricle to left atrium, this should not happen. If it happens, we'll call this as MR, that is mitral regurgitation. Means the mitral valve is incompetent, it is not closing completely. That is the reason why there is leaking of blood from left ventricle to left atrium during systole, that we call it as MR. So MR is the first differential diagnosis. Second is left ventricle pumps blood into the aorta. So aorta is also one way direction. So if you are getting blood again from aorta to left ventricle in diastole, it means the patient has aortic regurgitation. So there is more blood flowing into the left ventricle, that is causing increased volume. If the patient has ventricular septal defect, so if blood is flowing from right ventricle to left ventricle, this is VSD. we will this will also increase the blood flow. Other thing is ASD, that is atrial septal defect. So right atrium to right ventricle, right atrium to left atrium, there will be more blood flow. So left atrium to left ventricle, there will be more blood flow. That will again cause increased blood volume into the left ventricle. And one more thing which is remaining is patent ductus arteriosus. So this is patent ductus arteriosus is an abnormal connection between pulmonary artery and aorta. So this also again will increase the fluid volume or blood volume, and it will again cause increased left ventricular volume. So there are four causes: MR, AR, VSD, ventricular septal defect, atrial septal defect, and patent ductus arteriosus, where you'll get the apex which will be down and out. Now, how to differentiate? Now, it's very unique and peculiar because each and every disease has its own symptomatology or own findings. So, if it is MR, is very very common. Most of the time, it is rheumatic heart disease. Most of the time, patients are young female patients. It can be of any age, but in young female patients, if they are rheumatic heart disease, MS and MR, they are extremely common. What is the feature of MR? Most of the time, in 80% of the patients, you will have a pan-systolic murmur. You'll have pan-systolic murmur that can be heard. Now, pan-systolic murmur DD is VSD as well. I'll come to that as very soon. This pan-systolic murmur, and if it radiates to axilla, radiation to axilla is a very common feature of MR. So, if there is young female patient, if she has MS, MR, or if she has rheumatic heart disease, and if she has pansystolic murmur with radiation to the axilla with good volume of pulse volume, then this is highly suggestive of mitral regurgitation. You should suspect mitral regurgitation. One more thing, because of the mitral regurgitation, the chances of left atrial volume overload is very much there. So very commonly, patients may have uh, atrial enlargement sign, like enlarged or the P wave, which is more than 2.5 small boxes. So this is a very common feature of uh, left atrial volume overload or left atrial enlargement. Patient can very commonly have atrial fibrillation. So these all symptoms or these all things suggest that patient may have mitral regurgitation. Now, what does suggest aortic regurgitation? Now, aortic regurgitation is usually more common in male patients, in elderly patients. And in aortic regurgitation, what you can very commonly see, there can be increased volume of all the main arteries of the body. Like there can be prominent carotid dance. Means there the volume of carotid, bilateral, like internal carotid, external carotid, can be significantly there. They can be significantly apparent. So they look like with each pulsations, these carotid arteries become much more prominent, just like they are like dancing. You can see this brachial pulsations very well. You can hear the femoral pulsations very well. So all the arteries will be much more prominent. The fluid volume or the pulse volume will be very high. And what you can one more thing you can see, that systolic to diastolic difference becomes much more. So what we call it as pulse pressure will be very high. So it can be like the blood pressure is 150 and the pulse pressure, the diastolic pressure will be like 40 30. So you can see that pulse pressure is almost like 110 millimeters of mercury, which is not usually there. So prominence of this pulse pressure, prominent carotid arteries, brachial arteries, femoral arteries, is a very much common feature of aortic regurgitation. And what you can see, this murmur is much more prominent at aortic area, aortic region. You will not get this murmur much more prominent at mitral wall. There will not be radiation to axilla, and this murmur will be maximally heard at aortic area, and this axillary area or mitral area that may not be that much prominent. Very commonly, this radiation of aortic regurgitation murmur can be heard going towards the mitral area, but this murmur will be much more prominent at aortic area compared to mitral area. So this way you can have an idea that patient may have actually AR and not MR. Regarding VSD, VSD murmur is best heard at fourth, fifth intercostal space, and that too in parasternal region, because we know that the RV and LV, we have segregation of this, and we have this ventricular septum around the sternum. So you can hear this parasternal, you can hear this ventricular septal defect murmur much more prominent around parasternal region, both at right as well as left parasternal region are in around 4th to 5th intercostal space, and that is also a pan systolic murmur, and there will not be, this murmur will not be prominent at the apex area. There will not be any radiation to axilla, which is very typically seen with MR. And if the patient has right to left shunt, then patient can definitely show signs of cyanosis, and patients may have signs and symptoms since long childhood, because VSD is a congenital disorder. Regarding ASD, what we can see in ASD is you have fixed S2, means there is wide splitting of S2. So A2, that is aortic component and pulmonary component, they will be very, very nicely segregated, and there will be a fixed split between the A2 sound, that is aortic closure sound, and pulmonary closure sound. This is very interesting ASD feature, and you can see this double atrial shadow that can be seen in ASD because of the enlargement of left atrium as well as right atrium. And the last thing is PDA, that is patent ductus arteriosus. It is also a congenital disorder. One of the most important thing about this is what you can hear is a continuous machinery murmur. Continuous machinery murmur. It is like continuously sound that you can hear at factory, any factory, that is some or other machine is always running. If you want to compare it, it is just like an aortic uh, arteriovenous fistula that very commonly we see in CKD patients. So you can simply put your stetho on out at arteriovenous fistula in any CKD patient who is on maintenance hemodialysis. So that is typical continuous machinery murmur that is very typically seen in patent ductus arteriosus. One more feature of patent ductus arteriosus is differential cyanosis, because most of the time this patent ductus arteriosus actually affects only the outer part, which is beyond the right subclavian. So in short, right subclavian is spared, and the left subclavian, beyond left subclavian outer, is involved. So you don't see cyanosis in hand, but you see cyanosis in lower limb toes. So if the if the toe nail shows cyanosis and hand nail doesn't show cyanosis, it means the chances of patient having PDA with continuous machinery murmur is very, very high. So any patient with cardiomegaly with down and out apex can have these diseases. Apart from this, there can be others also, but these are most common and they should be always kept in mind. Thank you.